Hello, my name is Darolyn Perkins, and my topic is evaluation and management of hyperlipidemia in a primary care clinic. My community members included Chairperson Dr. Rachel Citron, Second Reader Dr. Maria Snell, and Community Liaison is Dr. Renee Amati. Hyperlipidemia includes cholesterol, triglycerides, low lipid protein cholesterol, which is called LDLC, and high density lipid protein cholesterol, which is called HDLC. These lipids function in the body, but when they are abnormal, they cause problems. Lipids are essential in cell membrane metabolism and in the production of hormones such as steroids and vitamin D. Excessive plasma lipid in the source of atherosclerosis leads to cardiovascular heart disease. Dyslipidemia, hyperlipidemia, and hypercholesterolemia are interchangeable and will be used in the scholarly project. Another common hyperlipidemia is familial hyperlipidemia. One of the most common causes is familial lipoprotein disorders. Its etiology is still not understood and will only be mentioned in its history. No other articles will be reviewed. They include high plasma levels in the blood. Hyperlipidemia, along with diabetes and hypertension, is the leading cause of cardiovascular disease. Hyperlipidemia is one of the major risk factors for clinical atherosclerotic cardiovascular disease, which is ASCVD. And it's a group of diseases with one of the major mortality incidents in the world. Unlimited control levels include blood plasma levels above 200 for cholesterol and greater than 190 for LDL and triglycerides greater than 240. The levels can be modified if caught in time and can be prevented. Hyperlipidemia is a chronic disease affecting over 65,000 people in the United States in the last year. If uncontrolled, it can lead to cardiovascular events such as heart attack and stroke. The lifestyle modification and risk assessment tool approach to lowering lipid levels was chosen due to its ease of implementation and availability. Lifestyle modifications and the ASCVD risk assessment are interventions that can be implemented by individuals with high lipid levels with or without medication that are in a targeted population. Lifestyle modifications include diet, exercise, smoking cessation, reduction in alcohol. The first line treatment for hyperlipidemia is lifestyle modifications. ASCVD assessment tool should be done on all new patients diagnosed with hyperlipidemia and then at 5 years and 10 years. And those who don't have one need to go back and at least do one to assess their level because the tool helps in identifying a modification risk, modification styles such as diet, and it recommends also if the patient needs to be on a medication or not, and what level of statin or other medication the patient needs to be on. Purpose and aim of the project was effectiveness of the implementation of an evidence-based hyperlipidemia guideline using an ASCVD risk assessment tool and lifestyle modifications. The primary purpose of this project is to improve and evaluate the management of high cholesterol in male patients at a primary care clinic using lifestyle modification risk assessment tools with or without medication to guide the treatment of hyperlipidemia. The risk assessment tools was used by some providers, but not by all. We aim to increase the percentage of providers using the tool and patients meeting their target cholesterol levels and reduce the risk of stroke and heart attack through education, sometimes medication, and a healthy lifestyle. The secondary aim is to increase provider knowledge of the disease risk assessment tool and contributing factors, and to increase the calculation of ASCVD risk scores in patients between the ages of 40 and 79 years from a baseline rate of less than 50% N equals 2 to 75% N equals 3 within 6 months for primary prevention of ASCVD. Lifestyle modification treatments and risk assessment can be successful in controlling high cholesterol. This will allow early intervention and reduce timely care associated with uncontrolled lipid levels and comorbidities such as stroke, heart attack, and other cardiovascular events. Controlling lipid levels in adult patients using lifestyle modifications versus medication can be a challenge. The DNP project aims to improve patient outcomes by lowering lipid levels, reducing hospital visits, and quicker interventions in case of a crisis. The DNP project is a quality improvement project to address provider and patient issues that contribute to uncontrolled cholesterol levels. My PICO question is geared toward improving the management of lipid control in adults in the primary care setting. The literature review provided solid support and evidence that lifestyle modifications and a risk assessment tool can help reduce lipid levels. All the studies were from primary sources. There were similarities in the articles and differences in some. All the information can answer the question if lifestyle modifications and a risk assessment tool can help reduce lipid levels, thus reducing cardiovascular events. The strength of the study is that it was free of misconduct. The research studies must protect the public and record information about the study that is factual, but also make judgments about the value of the evidence. The articles that were chosen were reviewed for fabrication, falsification, or plagiarism and show no evidence of either. Most of the studies noted that they received IRB approval by a similar research or ethic committee or met legal requirements. The articles again were for primary sources, and so the evidence was from the authors that exactly completed the study. The sample size varied with the lowest 17 participants and the highest 240 participants. The evidence critically reviewed shows strong support for lifestyle modifications and risk assessment tool assisted in the lowering of lipid levels. There were some weaknesses found in the study. Some of the studies were small, which didn't allow for a lot of information to be extracted from the study. There were some cross-sectional study designs used due to their ease of administration. However, they're generally considered weaker research studies due to collecting data only once, as opposed to over time, as in longitudinal studies. Of the article's critique, um, only one study was a cross was an all cross sectional in design. Gaps in literature. The DNP project of establishing that lifestyle modifications and assist in lowering lipid levels did have some gaps noted in the literature. Research evidence has shown a gap in that there are behaviors that assist in developing hyperlipidemia, and those behaviors are modified, but don't specifically state if the modification alone lowers or need assistance. The major gap found was most articles focused mainly on smoking cessation, and others focused on other lifestyle behaviors and lifestyles of the participants. Limitations. The limitations of the reviews are based on the article study. The study examiners were not exhaustive. They included some of the studies available in the database. There are limitations that are evident in almost all research, and the articles reviewed showed no exception. Some of the participants did not finish the study and did not complete the follow-ups. This can often dilute the treatment group and possibly skew the results. Participants are often aware of being part of a study, and this knowledge can affect the true results of the study. Participants can report information differently than if they didn't know that they were part of a study. framework was the change model by Kirk Lewin. The concept is strong and solid and used in nursing theory. This concept builds into your point of interest. A concept that builds into my point of interest is controlling hyperlipidemia in adult patients aged 47 is change. When one interest is improved, patient outcomes such as controlled lipid levels, reduced hospital admissions, reduction in cardiovascular events, and overall well-being. There must be a change in the way things are done. The theory that best fits this project is the change theory. Kirk Lewin is a founding father of change because he has contributed a lot in managing change successfully through different theories. His three-step model, which is unfreezing, moving, and refreezing. The three stages involve the unfreezing stage, including identifying the clinical problem, completing a chart review, and giving the providers a survey to complete. The second stage of change includes creating provided education and giving the providers the education. The third stage of change is lipid screening levels and provider practice changes. There are many behaviors a person can practice that can lead to damaging their health, such as smoking, drinking, overeating, and drugs. Small changes or even elimination of these behaviors can have a healthy outcome. If we understand these behaviors in the context in which they occur, we can develop effective evidence-based health behavior change interventions and policies for reducing avoidable mobility and mortality. Sometimes a person must change their whole way of living, such as diet, and this can be very scary. Lifestyle modifications require a change in one's behavior and modifying these behaviors to produce a healthy outcome. Diet, exercise, smoking, and alcohol consumption are all modifiable behaviors that can reduce the risk of cardiovascular events. Using the change theory, a person can make these changes. In methodology, the purpose of the scholarly, the needs assessment, um, discovered the purpose of why I did this project. It was determined whether timely screening using assessment tool, medication, and lifestyle modifications of hyperlipidemia would increase the identification, diagnosis, and management of hyperlipidemia among a certain population. The study seeks early screening of hyperlipidemia in males aged 40 to 79 using ASCVD risk assessment tools and lifestyle modifications such as diet, exercise, smoking, and reducing alcohol intake. Methodology used is a quantitative exploratory design conducted through a retrospective chart review of patients' records using the electronic medical record to determine the risk for cardiovascular events and the effect of lifestyle modifications on lipid levels. There was a total of 102 charts for primary care clinic with uncontrolled hyperlipidemia. The charts that were reviewed, only 52 charts met the inclusion and um, criteria, which I will talk about later. Approval from the Maryville Internal Review Board was required for the project to begin. The clinic where the project took place did not require additional IRB approval. The interventions included an ASCVD risk assessment tool, lifestyle modification, and retraining for primary care providers. Patients' height, weight, their BMI, their LDL, their cholesterol, and their HDL levels were collected from the patient's chart. Also was collected if the patients had a documented ASCVD risk assessment score and they had documented lifestyle modification education. The design help collects the data to be used. It shows how data will be collected and what types of data will be collected. It also specifies where the data will be collected and what it would be used for. A quasi-experimental design was used for this quality improvement project with data collection from a retrospective chart review, pre and post interventions. The setting is an independent primary care with 3 locations in the western part of the United States and 1 in the eastern part of the United States. Like I said, the data was extracted from the electronic health records of males of all races ages 40 to 79 diagnosed with hyperlipidemia in the target primary care clinics and approved by the clinic owners. Patients will be assessed using an ASCVD risk assessment tool. Patients with hyperlipidemia who were seen at the clinic during the project's 6-month timeline was reviewed for potential inclusion in the retrospective chart review. The pre-test data was collected from January the 16th to February 16th, and post data was collected from July 16th to July 31st, 2023. The exclusion criteria was the patients had to be under the age of 40 and over the age of 79 due to the measurement of the ASCVD risk measurement tool measures from age 40 to 79. The date of birth will be used to determine the age, and no females will be used in this project. The inclusion criteria included males only between the ages of 40 and 79. They have to have a diagnosis of hyperlipidemia, and they could either be on or off lipid-lowering agents. In the Western primary care clinics, the patients diagnosed with hyperlipidemia, and there were ages 40 to 79 males, and there were 50 males, 60 males pre-intervention and 60 males post-intervention. Human subjects included CITI training, IRB approval from Maryville University. All data collection was password protected. It was locked and there was limited access only to the researcher. Patient identifiers were removed and the data was destroyed after it was entered into the Excel document. Analysis. Data was extracted from the chart using the data collection sheet with the variables of height, weight, BMI, LDL cholesterol, total cholesterol, and HDL cholesterol. Data collected sheets it was transferred to Excel, and then it was transcribed into SPSS using Maryville statistician. The Kolmogorov and Smirnov and Shapiro-Wilk normality test was ran, and then it was determined that it was not a normal distribution, so a Mann-Whitney U-test was decided on the test to use to find if the information was statistically significant. Mann-Whitney U-test was the statistical test recommended by the statistician to analyze the data. The sample size was a total of 60 participants, 50 participants for the intervention group and 10 for the comparison group. The participants were all males between the ages of 40 to 79. Sample size met the requirements for a Mann-Whitney U-test to have an effect size of 0.5, a significance level of 0.05, and a power of 0.8. The providers consisted of 3 medical doctors and 1 nurse practitioner. The test was run on the weight, the BMI, the cholesterol, the LDL, and HDL levels. The standard deviation was used to assess the degree of variability. The significance for the cholesterol, BMI, and LDL was not significant. The significance for the HDL came back to less than P greater than 0.001. This showed a statistical significance for the HDL. The statistician calculates the effect size as Z sample size minus 1 for each test. The effect size for weight was 0.05, BMI was 0.05, and cholesterol was 0.16. LDL was negative 0.08, and HDL was negative 0.45. HDL showed a moderate sample for this study, N equals 50 and N equals 10, which means that 69% of the control group is below the experimental group's means, but it is a clinical meaning for size. Cardiovascular disease risk assessment tool and lifestyle modifications were helpful in the management of hyperlipidemia in a primary care clinic. Study results revealed a statistically significant improvement in the HDL levels of patients, p greater than 0.001. It did not show a statistically significant improvement in weight, BMI, cholesterol, and LDL levels. Provider knowledge and the use of the ASCVD tool increase post-intervention. These findings mean that the ASCVD risk assessment tool is an effective intervention in managing hyperlipidemia. Areas included not enough providers wanting to participate in the project. The pandemic continues to be a barrier in that masks are still required, and most patients do not want to visit the clinic. There was less scheduling of appointments and follow-ups due to not wanting to have many patients in the waiting area. The sample size was smaller than normal. The electronic health record did not have an integrated ASCVD risk calculator. Time framing was 6 months, which should have been longer. It should have been a year study. Um, and I was unable to reject the null hypothesis. Patients who are diagnosed with hyperlipidemia are not managed and treated according to the guidelines for CDC and ACC and AHA. Patients who are diagnosed with hyperlipidemia are not controlled, and they are at a high risk for cardiovascular events such as heart attack and stroke. Providers are not completing follow-up visits for patients with high lipid levels. Providers play a major role in evaluating and managing hyperlipidemia. Hyperlipidemia can be managed with providers' awareness and accountability for their patient care. Future research should examine comorbidities such as diabetes, hypertension, and specific diet. There should also be more research on medications such as statins. Qualitative research should be done on the ASCVD tool and its associated with prescribing medication for hyperlipidemia. Have shown that the ASCVD risk assessment tool and lifestyle modifications are effective interventions for managing hyperlipidemia. Therefore, it was expected that the ASCVD tool and lifestyle modifications will be effective in managing hyperlipidemia in a primary care clinic. The results showed that it was statistically significant for HDL. There was no statistical evidence to support other changes such as in the weight, the cholesterol, and the LDL. There was inconsistency in practice identification. Some providers used it, some didn't because of overload and stress. It's recommended that all providers use the ASCVD tool on patients who are at risk for cardiovascular events. It's also recommended that there be an integrated alert to alert providers when there is a ASCVD risk assessment needed and if it's done or overdue. Using lifestyle modifications in the ASCVD risk assessment tool has shown, even though it was not statistically significant, it was clinically significant because all the evidence-based guidelines suggest that a pool cohort equation tool be used in the assessment of hyperlipidemia, and the ASC VD is one of the tools that can be used to identify. It also helps identify what medications to put on, what type of lifestyle modifications that can be used. So it does have a positive impact on the patient's health. And this project would have a positive impact on patient health with positive outcomes as they are evaluated and managed appropriately according to evidence-based guidelines. If there are any questions, you can contact me at darolyn47@gmail.com. The next several slides are my references for the project. Thank you and have a nice day.